Hello everyone and welcome to Neurosurgery Basics. Today we are going to be discussing back pain and its evidence-based management. Now, low back pain is the most common spinal disorder. Almost 1 billion people over the world have been affected by low backache at some point in their lives. And the thing is that most low back pain is non-specific. But a few important points about low back pain. Non-specific low back pain is often ignored by surgeons. And pharmacological treatment should be the last resort when it comes to low back pain treatment and not the first line of treatment as we usually follow. So there's a lot of changes which have to be introduced based on evidence when it comes to the management of low back pain. Now, when we evaluate any patient with low back pain, what should we look for? Basically, if any patient comes to your clinic with low back pain, perform a history and examination to triage the patient into 3 categories. The categories being non-specific low back pain, which will be the most common type, about 90 to 95% of patients. The other 2 categories being radicular syndrome and specific spinal pathology. Now, these 2, radicular syndrome and specific spinal pathology, can be diagnosed based on certain criteria in history and examination. But non-specific low back pain is a diagnosis of exclusion. It should be considered only after ruling out specific spinal pathology and radicular syndrome. Now, how do we identify that a patient has a specific spinal pathology? So there are some particular red flags that we should look for, which will help us pick up on specific spinal pathologies. These pathologies have particular red flags that we can look for. The important pathologies being vertebral fracture, where you'd want to consider older age being important, prolonged corticosteroid use, severe trauma, presence of any contusion or abrasion in the region which could indicate that the patient has suffered a trauma. If you're suspecting based on these red flags that a patient might have a vertebral fracture, what should you do? You should immediately get some imaging for patients who have a major risk for a fracture. And if it is a minor risk, you can actually delay the imaging for some time and give them a watch and wait trial and see what happens. But that's only for patients who are at a minor risk of a vertebral fracture. And you can get an ESR to look for any changes. If a vertebral fracture is evaluated and found out to exist, you refer the patient then further to a spine surgeon. Second, if on the basis of any of these red flags, a history of malignancy, strong clinical suspicion of a malignancy, unexplained weight loss, age more than 50 years, then you can suspect that the patient might have a malignancy. And in that case, again, if you have major risk factors, then you can do an immediate imaging. But if it's minor risk factors, you can again wait and watch and see if the symptoms go away and do a delayed imaging. Again, for this patient, you would like to get an ESR done. Okay, and if you find that there is a malignancy, please refer the patient to an oncologist. Now, what is the imaging which should be performed? Now, that really depends on the specific spinal pathology you're looking for. So if you're looking for a vertebral fracture, then the imaging that needs to be performed would most likely be a CT scan. But if you're looking for a malignancy, then more likely you would like to perform an MRI rather than a CT scan. If you're looking for widespread malignancy, it might even be a PET scan. Right, a very important diagnosis which could also be found is axial spondyloarthritis. It is not as common as we think, so we're not going to find it very frequently, but when found, it requires particular treatment, and that's why it is important to identify spondyloarthritis. Now, what are the different red flags which can help you figure it out? There are some very particular things. Usually, the patients will come to you with chronic back pain, which will be for more than 3 months duration. The back pain would have started before the age of 45 years, and they may have one or more of the following. The back pain is inflammatory. Okay, and to say that a back pain is inflammatory, you require at least 4 of the following. That the age at onset is 40 years or younger. It's an insidious onset. It improves with exercise, which usually mechanical back pain will not, but inflammatory back pain will. This does not improve with rest. Mechanical back pain will improve with rest, while inflammatory back pain will not. And there is pain at night. Now, pain at night can happen either because of inflammatory back pain or because of malignancy. But if you look at the other factors like improvement with exercise, no improvement with rest, it can help you identify inflammatory back pain. Apart from just inflammatory back pain, the patient might also have some peripheral manifestations of inflammation like arthritis, enthesitis, or dactylitis. Some extra articular manifestations like psoriasis, inflammatory bowel disease, or uveitis. They might also have a positive family history of spondyloarthritis. And they usually will respond very well to anti-inflammatory drugs. Now, if you're strongly suspecting that the patient has spondyloarthritis, do not really worry about doing any diagnostic workup. Just directly refer them to a rheumatologist. A less frequently found cause of back pain might be spinal infection. Usually you'll find that these patients have the following red flags of fever or chills. They might be immunocompromised. The pain, as we discussed, for inflammation usually happens at night. They might be an IV drug user, or they might have had a recent injury or a dental or spine procedure which has led to dissemination and this spinal infection. These people who, when you're suspecting them to have a spinal infection, you should get an immediate MRI and lab test like a CBC, ESR, and CRP, and refer them to an infectious disease specialist to take care of this infection. The next and the last specific spinal pathology is cauda equina syndrome, a significant emergency. We're going to come across cauda equina syndrome very, very frequently as neurosurgeons. Red flags which point towards the cauda equina syndrome include new bowel or bladder dysfunction along with low back pain, perineal numbness or saddle anesthesia, and persistent or progressive changes which are indicative of LMN or lower motor neuron involvement. Okay, any patient with cauda equina syndrome, get an immediate MRI and refer them to a spine surgeon. That could be you, that could be another person. Right, so these are the different types of specific spinal pathologies that we have discussed, from vertebral fractures, malignancies, axial spondyloarthritis, spinal infections, and cauda equina syndrome that we are more likely to encounter in our practice. And what are the different red flags we should look for, the different diagnostic workups we should do for these, and if we find out or we highly suspect for these pathologies, then where do we refer these patients to? The next syndrome, which might be the etiology for low back pain, is radicular syndrome. To identify radicular syndrome, within radicular syndrome, there are multiple different pathologies which can exist. Either the problem could be radicular pain, it could be radiculopathy, or it could be lumbar spinal stenosis. So let's look at what are the different features which could indicate these three conditions. So when it comes to just radicular pain, remember radicular pain is not the same as radiculopathy. In radicular pain, you will only have pain. In radicular pain, you would not have features of nerve involvement like weakness and like sensory loss. Okay, you should only have radicular pain. Now, when it is radicular pain, you'll find that the leg pain is typically worse than the back pain is. And the leg pain is of typical radicular pain type. It is sharp, it is lancinating, or it is a deep ache, which will worsen when the patient coughs because of an increase in the intradiscal pressure, or when the patient sneezes, or any sort of straining which increases the pressure. The usual location of leg pain would be, it would usually be unilateral, and it would follow a particular dermatome, and it would extend below the knee when the radical involved is L4, L5, or S1. Now, when a patient has only radicular pain, which means that the nerve root is being compressed but does not have radiculopathy, the only physical examination which would be positive is the provocative test which you can do for dural irritation. Now, there are two. For the lower nerve roots, L4, L5, S1, and S2, we can do an SLRT or the straight leg raising test. For higher roots like L2, L3, and L4, you should turn the patient prone and then bend their knee. That's a prone knee bend test. Right. Sometimes lumbar extension and flexing on the same side okay, that's ipsilateral side flexion, may exacerbate radicular pain. So this is known as Kemp sign. So it's very similar to Sperling sign that we have for cervical radiculopathy. Right? So sometimes radicular pain may accompany radiculopathy signs, but remember, radicular pain and radiculopathy are different entities. Radiculopathy, on the other hand, does not necessarily need to have radicular pain associated with it. So pain is different and radiculopathy is different. Now, radiculopathy is where the conductive ability of the nerve root has been affected. So there will be both sensory and motor disturbances. So in history, you'll find weakness and you'll find numbness or paresthesias. Okay, so important to differentiate pain and numbness or paresthesias because these can easily be confused by both the patient and the doctor. Right? And sometimes they might even think of weakness and numbness. So it is very important to go ahead and clarify what they mean. Are they talking about pain? Are they talking about paresthesia? Are they talking about numbness? Or are they talking about weakness? Right? On examination, you'll find the usual sensory disturbances, myotomal weakness, and absent or reduced reflexes. The third syndrome which can exist is lumbar spinal stenosis, which can also cause radicular syndrome. Now, what happens in lumbar spinal stenosis is there is a narrowing of the lumbar canal. Now, this narrowing will worsen when the patient starts walking because of venous congestion. Okay, so this is what is basically known as neurogenic claudication. And neurogenic claudication happens when the patient walks for a little bit and then all the venous congestion leads to significant pain which limits their walking tolerance. Right, so that is basically neurogenic claudication, and neurogenic claudication is more or less diagnostic of lumbar spinal stenosis. Now, usually it is found in older patients. They will have bilateral leg pain in lumbar spinal stenosis, and they might have cramping. They might not even have lower back pain. Now, what is different here is that, as we have discussed, they'll have bilateral leg pain, unlike radicular pain, and it will be exacerbated in an extended posture because lumbar extension decreases the lumbar canal space and will be relieved by flexion. A very important finding in lumbar spinal stenosis, the leg pain will be exacerbated by extension and relieved by flexion. Examination in patients with lumbar spinal stenosis most likely will end up being normal, especially when they're at rest, when there is no venous congestion, nothing to worry about, then they'll usually have a normal neurologic assessment. Now, you can ask them to walk, and you'll usually see that even when they stand, they'll stoop a little bit because they have to flex their spine. And when they walk, again, they will walk with a flexed spine. And if you make them walk long enough, the neurogenic claudication might get triggered. Right. So now let's come to the evidence-based treatment algorithm for patients who are presenting to us with low back pain. So we've already discussed the diagnostic triage, which is basically based on the focused history and physical examination. We triage the patient into 3 specific pathologies. We look for specific spinal pathology and we look for radicular syndrome. If we have ruled both of these out, then we can say that it is non-specific low back pain, which is a diagnosis of exclusion. Right. So we already know what to do with specific spinal pathology. We have discussed that in detail. You just look for the particular pathology which exists and refer the patient appropriately after the particular diagnostic protocol which has to be followed for that condition. Now, what do we do for somebody who has a radicular syndrome? So radicular syndrome could be anybody presenting with radicular pain or radiculopathy. Now, first, we have to ask these 4 questions. Are there any disabling symptoms which are lasting longer than 6 weeks? Have they already been given conservative care, and has that conservative care proven insufficient? Is there any severe or progressive neurologic deficit? And is there presence of cauda equina syndrome? If any of these questions are yes, then the patient needs to usually undergo spine surgery and they should be referred to a spine surgeon. If you are a spine surgeon, the first thing obviously you will be doing for this patient is getting an MRI. And based on the findings of the MRI, whatever decompressive surgery is required for this patient can be offered. Now, if answer to all the questions is no, that means that the symptoms are lesser than 6 weeks, they might not have received conservative care, they do not have any progressive or severe neurological deficit, and they do not have cauda equina syndrome, then if for a patient with radicular syndrome, we can consider imaging. This is important to remember that if the patient has radicular syndrome, does not have any of these 4 questions, you can still consider imaging. Most likely you will go ahead with imaging. But if it was just non-specific low back pain and no red flags, then you would not consider imaging. So just remember, this is a very important thing. Imaging should only be considered for radicular syndrome, even if the answer to all these questions is no. Okay. Apart from imaging, if you can notice here, we have put medication as the last thing here. Okay. So usually what we are used to in our normal routine practices, patient comes in, has radicular syndrome, we consider imaging. If imaging suggests surgery, we offer surgery. If imaging does not suggest surgery, we offer medication, and then that is it. That is the end of the story. What we need to do before we offer medication is step 2, step 3, and step 4. We need to counsel the patient. Okay, it's very important to provide reassurance and advice. When it comes to actually assessing what are the different interventions which work for patients with low back pain, the intervention which was shown to be very effective and work in almost all trials was advice. Okay, so it's very important to just stop, provide reassurance and provide advice about the diagnosis and about treatment and how it is a curable disease and can be taken care of. Apart from that, physiotherapy and rehabilitation are 2 important things which need to be taken care of. We'll discuss this a little bit more detail later. And then when these 3 are taken care of, then the patient can be offered medication, right? The first line for medication, even with radicular syndrome, is NSAIDs. It is not gabapentin, not pregabalin. The first line is just NSAIDs given for a short duration, okay? And then along with the NSAIDs, obviously, we should have given advice, physiotherapy, and rehabilitation. Now, this has to be given over a course of 6 weeks, and we have to wait and watch and see what happens after 6 weeks. Again, when the patient comes back after 6 weeks, you have to go back and ask these questions all over again. If at any point in time in these 6 weeks they have developed disabling symptoms, progressive or severe neurological deficits, cauda equina, then again, probably have to refer them for surgery. If they have not, then we can go on to a second line treatment, which would be a trial of neuropathic medications. Here is when we can introduce gabapentin and pregabalin. And we want to continue education, physiotherapy, and rehab. After 6 weeks of first line treatment, you can consider now referring the patient to a spine surgeon again. Or you can just give a trial of neuropathic medications and physiotherapy and rehab and then see again for 6 weeks. Now, if again after 6 weeks they come back to you and they still have not recovered from the radicular syndrome, you would like to refer them for surgery at that point, most likely. Okay, so that was for radicular syndrome. Now we'll discuss the treatment algorithm for non-specific low back pain. Remember, non-specific low back pain is a diagnosis of exclusion, and you have to rule out specific spinal pathology and radicular syndrome with history and examination. Now, non-specific low back pain has to be treated differently for acute onset and chronic or persistent onset. Acute onset is defined as less than 3 months duration, and chronic onset is more than a 3 months duration of symptoms. Now, for patients with an acute onset of low back pain, which is non-specific, very clearly, based on evidence, do not perform imaging. Okay, that is the most important thing. Okay, acute non-specific low back pain, do not perform imaging. Okay, a very important thing here is to reassure patients about a favorable prognosis. Tell them that 90-95% the symptoms will resolve, nothing to worry about, and they should not really think of it as a long-term disease which will lead to limitations with their activities of daily living. So the most important treatment here is actually reassuring the patient about a favorable prognosis. Then last thing is medication. Again, we prefer NSAIDs. Paracetamol can be considered if NSAIDs are contraindicated. Okay, but again, remember, treatment first line is just NSAIDs. This is low back pain, this is not radicular syndrome. Okay. Even for radicular syndrome, pregabalin and gabapentin have not been proven to be a recommended drug. Okay, we just do not have conclusive evidence about the efficacy of gabapentin and pregabalin in radicular pain. So even for radicular pain, we consider NSAIDs as the first line, and for any low back pain also we consider NSAIDs as the first line treatment. Okay, since this is acute onset pain, we can reevaluate the patient within 1 week also. Okay, and then check if there is no improvement. If there is no improvement within 1 week, then you want to go ahead and provide structured patient education, which is a little bit more than just providing them reassurance. And we'll discuss what is structured patient education next. Apart from that, we have to provide them the supervised exercise protocol, which would be carried out by a physiotherapist or a rehabilitation center. And now you can consider your second line medications beyond NSAIDs. Okay, only for acute onset, you can consider a short duration of muscle relaxants, a very short duration of opioids, and you may consider some antidepressants. We'll discuss what these are later on. Right, so this here is structured patient education. Now this structured patient education actually has to be provided by a psychologist and a physiotherapist acting together. Okay, this is not the job of a neurosurgeon, this is not the job of a primary physician, but this has to be done by a psychologist and a physiotherapist. Now, structured patient education is usually performed under 4 categories, and it is recommended that it has to be performed basically, every category should be separately done in separate sessions, and the session should last for at least 20 minutes, right? So you would likely have 4 sessions, 20 minutes each, covering these 4 different categories. The categories are mechanisms and course of low back pain. So basically, first thing is you're trying to tell them why the low back pain has developed. The next category would be what they should do about physical activity. Third would be how can they manage the low back pain themselves. And then fourth would be what can be done for the medical management of low back pain. So in the first category, mechanisms and course of low back pain, we would just give them a basic primer on how spine anatomy and pathology works, what are the structures of the back, and how were they damaged, how back pain has been caused and experienced, and then the basic idea is that we want them to understand that this is a benign condition and has a good prognosis. Second is physical activity. Now, physical activity, usually we want them to basically not rest and stay active as much as possible. So we want them to avoid bed rest, stay active, or return to activity slowly. They want to return early to work, and we can give them specific exercise recommendations. Again, remember, this is the job of a psychologist and physiotherapist. This will be a structured education program, which needs to be carried out at least over 20 minutes with each session. Okay, then third, self-management of low back pain. That is where we can discuss with them pain management and coping skills. How can they cope with their pain? How can they manage stress? And how can they avoid or minimize the pain? And fourth would be discussing the further diagnostic tests and treatment options. Remember, in acute non-specific low back pain, we have not done imaging. So in one of these education sessions, we can discuss with them what are the further diagnostic tests which can be done and what are the other treatment options. Okay, now coming to chronic non-specific low back pain. Now this is low back pain which has lasted for more than 3 months, right? Now, so it is recommended for patients who have chronic non-specific low back pain to perform something known as a start back screening tool. Okay, and over here on the right we have the start back screening tool. It's basically just 9 simple questions with a very easy scoring system. Okay, so here there's a disagree gives you a 0 and an agree gives you a 1 score. Simple straightforward question. My back pain has spread down my legs at some time in the last 2 weeks. I've had pain in the shoulder or neck at some time in the last 2 weeks. I've only walked short distances because of my back pain. In the last 2 weeks, I've dressed more slowly than usual because of back pain. It's not really safe for a person with a condition like mine to be physically active. Worrying thoughts have been going through my mind a lot of times. I feel that my back pain is terrible and it's never going to get any better. In general, I've not enjoyed all of the things I used to enjoy. The last question is overall, how bothersome has been your back pain in the last 2 weeks? That can be graded from 0, 0, 0, which is not at all, slightly and moderately, to very much and extremely. Amongst all these questions, the scores of the questions between 5 and 9 are a little bit more important, and we'll see here why. So in the start back screening tool, if the score turns out to be 3 or lesser, then it is a low risk. What we're trying to quantify here is the risk of chronicity. A very important concept to understand is that non-specific low back pain, particularly chronic non-specific low back pain, is not just an anatomical problem. Okay, apart from anatomy, there is a psychological involvement and a social involvement. So together, these are biopsychosocial factors which lead to the chronicity of pain. So we can't just simply go ahead and fix the anatomy. Just surgery or just pharmacology will not work. There are a lot of psychosocial factors which have to be corrected in patients who have chronic low back pain. Okay. Now, if the score on the start back screening tool is 4 or more, then we need to further figure out what is the score of only questions 5 to 9. If the scores of question 5 to 9 come out to be 3 or lesser, then it is medium risk. If the scores of questions 5 to 9 are 4 or more, then it is high risk. And then we have particular protocols for these particular risk categories, which are, so for a low risk package, okay, it's basically to just provide support and enable them to manage the pain themselves. Okay, so it is chronic non-specific low back pain with low risk of chronicity. So we'll just provide them with some basic advice and some particular therapies to really allow them to manage the pain themselves. Okay, so the components of a low risk package would be that they just need to have a one-off consultation with clinician. That's all, just one time meet a clinician. The assessment at that time should include medical issues, but we also want to really bother with what's the social impact and what are the patient worries and concerns. We can do a brief physical assessment, and this is important. It has been shown that when you do a physical assessment of patients, even with non-specific low back pain, it does lead to better outcomes. We can review their medication and advise what they should instead be taking. And whatever we have assessed and found out to be problematic, we can address these specific patient issues. Basic idea is that they should be able to manage this back pain themselves and explain to them that outlook is good because they're in the low risk category. But if it continues to bother them, they can reconsult if necessary. On the other hand, slightly higher risk is a medium risk package. Now, here the idea is not just self-management, it also includes self-management. Beyond that, we're trying to restore function and minimize disability. Now, the thing with non-specific low back pain is a lot of times this non-specific low back pain does not go away. So even if it does not go away, we have to try and minimize disability and restore function as much as possible. So the components of the medium risk package will obviously include all the components of a low risk package, but beyond that, your physical examination should be a little bit more in detail. Okay, then based on the physical findings and specific needs or worries of the patients, you can tailor the treatment. Now, in the medium risk package is when you would consider physiotherapy. There's no need to consider physiotherapy for the low risk package, where remember we're trying to basically help them self-manage their pain. But in the medium risk package is where we would consider physiotherapy. And some specific therapeutic interventions like manual therapy and specific exercise. They can do some general functional activities where there's no significant trigger for back pain. And remember, for all the therapies that you cover under this, there should be a particular end time point. They should not go on forever. They should be given for a particular duration. Coming finally to the high risk package, this is where patients are at very high risk of having chronic pain which does not resolve. The aim for these patients is they are not going to be able to manage their pain by themselves. So that is not what we're trying to do here. What we're trying to do here is reduce pain, reduce disability, and more or less improve the psychological functioning. Remember the biopsychosocial components of low back pain. So here, the components are very structured physiotherapy. I need to have at least 6 individual physiotherapy appointments over 3 months, lasting 45 to 60 minutes, which need to have both a combined physical and a cognitive behavioral approach. You should enable patients to manage ongoing and future episodes of back pain. Okay, so whatever they develop later on, they should be able to manage themselves after this physiotherapy sessions are done. An important component, as we've discussed, is correct all the biopsychosocial factors which lead to pain and identify potential psychosocial obstacles to rehabilitation. Right, so that was about the management of chronic non-specific low back pain. Just we have to use a start back screening tool, identify which risk package they belong to, and based on this, decide what will be the appropriate treatment. Low risk package basically just teach them how to manage the pain themselves. Medium risk package is where you would introduce physiotherapy and still try to make them be able to manage the pain themselves. And in high risk package, you're really worried about treating the biopsychosocial components apart from structured physiotherapy resources. Right. Finally, coming to the different medications. I know that this is what we're really interested in, but remember, medications should be the last line of treatment for back pain. Now, for patients with acute non-specific low back pain, the first line drugs are NSAIDs, right? Diclofenac and ibuprofen. Doses are mentioned here. Paracetamol is again not very effective, but can be considered for patients who we cannot give NSAIDs. When first line treatments fail or do not work sufficiently, second line drugs can be considered, which is an opioid like tramadol or a muscle relaxant like cyclobenzaprine. Maximum 7 days, again a very short duration. Monitor and always remember that a lot of patients might have addiction potential. Always ask if they're already alcoholics and smokers, which means that there's a very good chance that they could get addicted to other substances also. Particularly with NSAIDs, make sure that you're monitoring for side effects. Now, the drugs for chronic non-specific low back pain, the first line drugs are still the same. First line drugs for chronic non-specific low back pain are not pregabalin and gabapentin. They're diclofenac and ibuprofen or other NSAIDs. Paracetamol can be considered. Second line, when these have not worked enough, then you can consider, again, the first thing you should actually consider before you consider pregabalin and gabapentin is duloxetine or antidepressants. Particularly duloxetine has been tested, so it can be given. You can give it for 7 days again as 30 mg OD followed by 60 mg OD to continue. Pregabalin can be given at 75 mg HS to start with. If they're tolerating this, then BD, but remember the side effects of pregabalin and gabapentin are quite significant, okay, and they can limit function. So you should consider pregabalin and gabapentin only in patients where your NSAIDs and tricyclic antidepressants have not worked. If you're giving gabapentin, start at 300 mg OD for day 1, 300 mg BD for day 2, and then you can continue 300 mg TID. Tramadol can be given, but again, remember, only for 5 to 7 days. Right. So to finally finish this off, this is basically what evidence has found when it comes to low back pain recommendations. We're going to discuss what is strongly recommended, what is recommended, and what is not recommended to do. Right. So a very important thing, if you notice here, is this is against, which means that we should not routinely image people who have non-specific low back pain. It's very clearly mentioned in all guidelines for low back pain, do not routinely image non-specific low back pain. Okay, what we should strongly do is the diagnostic triage, as we discussed at the beginning of this presentation, assess red flags, and use the start back risk screening tool for chronic non-specific low back pain. What is recommended, but not strongly recommended, is that for patients who have pain, you can assess the pain severity using either visual analog scale or the ODI. Okay, again, not strongly recommended, but recommended. For patients who have persistent low back pain, more than 3 months, or those with symptoms of radiculopathy or spinal stenosis, that's when you consider imaging. Again, not a strong recommendation, but recommended. Right? So we know for radicular syndrome, we are going to consider imaging, but even beyond radicular syndrome, for non-specific low back pain, which is lasting more than 3 months, imaging can be considered. Right, but these are the treatment recommendations, again, based on evidence, we can classify them as what is strongly recommended, what is recommended, what is not recommended, and what we do not know works or not. A few important things I'd like to point out first is anti-epileptic drugs. Those are your gabapentin and pregabalin. We do not have enough evidence. It is still in the inconclusive category. We need more evidence before we can say it actually works or it does not work. For patients with non-specific low back pain, facet joint steroid injections and intradiscus steroid injections also do not have conclusive evidence. Right. Things we should absolutely not be doing. Okay, so initially it was thought that chronic non-specific low back pain might be because of infection, and so they used to give antibiotics. Absolutely not. Do not give people with non-specific low back pain steroids. Absolutely not. Bed rest is to be avoided at all costs possible. Please do not suggest bed rest for anyone. Do not do traction. Do not give them lumbar belts. A very important concept here. Non-specific low back pain. Patients without instability, do not give them lumbar belts. Okay, don't give them corsets, orthotics, etc. Electrotherapy does not work, so that's TENS. It will not work for non-specific low back pain. Ultrasound therapy. So these two things, TENS and ultrasound, are what physiotherapists tend to do very commonly. They do not work and they should not be used. Okay, laser therapy, orthosis, shortwave diathermy, that's heat. Current therapy, magnetic fields do not work, do not use them. Cold thermotherapy does not work, but heat thermotherapy, particularly for acute non-specific low back pain, does work. So a heat pad can be used. Okay, but cold therapy does not work. Intramuscular, spinal, epidural, or nerve block injections, not steroid block injections, should not be used. We do not know if steroid injections work, but block injections should not be used, and epidural steroid injections also should not be used. Right. What absolutely does work and is strongly recommended, the most important one, is information, education, and self-care. NSAIDs are strongly for, okay, right? So remember, a very common thing we do when we see patients with back pain is prescribe pregabalin or gabapentin, which here is in the inconclusive category. What we should be prescribing is just NSAIDs and seeing what happens with that. Prescribe NSAIDs, provide some education, let them do some self-care, provide referrals for physical therapy, for psychological therapy, some educational interventions, multidisciplinary treatment, right? Can also consider paracetamol, okay, if required, opioids and tramadol. For acute non-specific low back pain, muscle relaxants. For chronic, tricyclic antidepressants. Some therapeutic aquatic exercises, educational interventions, yoga can be done. For physiotherapy, rather than focusing on TENS and ultrasound, they should be focusing on spinal manipulation and spinal mobilization and clinical massage. Not relaxation massage, but clinical massage. Acupuncture actually also can be considered. And sometimes, if required and appropriate, a referral for surgery can be done. Right, so these were the references for this lecture. And that is all for today's lecture. Thank you so much for attending.